We're looking for pediatricians, and it's arguably the best place to practice pediatrics in the province. And I'm not just saying that. It's got fantastic hospital work, office work, and if you want to really practice pediatrics, we're far enough away from Vancouver. You have to deal with shit on your own, and we're close enough that we can always refer if we need to. So just have to do that because I think some of my colleagues are on the line, but it really is a great place. And you can also afford to buy a house, which is something that seems to be going out of style down here. You notice I'm wearing my shark shirt. Okay, that's because we're talking about billing, and we want you to make money. That's the whole purpose of it. But you can't be a greedy shark. And the thing about billing that's tricky is it's really just because your bills go through doesn't mean you're billing right. And you can basically bill what you want, and as long as it doesn't ring any bells, I mean, it will be paid. I mean, if it goes through a computer which checks certain things, it's going to be paid. It doesn't mean that you've done the work or anything to that extent, and you don't want to be audited. The likelihood of that is remote, and Todd's one of the people who does those audits, so he's a nice guy, so it's unlikely to nail you, but you don't want to be greedy. So we're going to start with pediatric billing, and we'd certainly encourage you. Is it okay if they interrupt if they have questions? Okay, so if you've got questions, just interrupt anytime, and we'll go. We've never gotten through one of the slide decks yet, and we don't really want to, so let us know, okay? But we're going to start at the basics because we see a lot of fairly young faces here. How do we change slides? I mean, these are just, you need to have somebody refer you. If you're doing a consult, you need a referral. There are codes in the MSP manual. If it's an out-of-town pediatrician or GP who refers you, there are codes that can be used. If somebody retired, there's codes that can be used. So it's pretty easy. You just have to have somebody that refers you. Obviously, the one thing that is important is if you've got neonates, which Todd certainly, well, he does shadow billing, but I do real billing, so I like to being paid for them. It's really important. It's way easier to bill them on their mom's PHN. So when they come out, they've got a name, and it's called baby boy or baby girl. So two very unique names, and you want to use the mom's PHN, and you want to add a 66 at the end. If you're in a Curo, for example, if you check infant, it automatically puts those 2 digits in at the end, and you're billing on the mom's code. And you can do that for 3 months, which means if it's November 29th, you do it for November, December to the end of January. So 3 months is kind of a vague thing because it includes the month they're born. Twins. You put a note in the billing field. I don't do that. And what I do is I bill under the twins PHN, which means that you're a bit delayed because basically until the mom registers the babies, you don't get paid, and that doesn't happen automatically. So I mean, if mom plops out a baby, you can bill under her code. But if they're twins, what I've found anyway is it's just a mess, and I was getting a lot of rejections, and it's just was easier just to wait till they were registered. So I bill under their PHNs with their names and wait.
There's a few people just taking note. And I think we can talk to Stephanie and probably put this on the BCP's website. There's also a link at the end for the UBC CPD about a billing talk also. So just so you know, this can be available. So obviously take your own notes, but we can make this available.
Any questions so far? Obviously, you need a date of service. Most of the codes that we use actually aren't time-based. So my Curo software automatically puts a time, which is usually inaccurate, and usually I don't change it for a consult. But there are a number of time-based codes, and there is very important to put that in the billing feed. So I mean, our office visits, for example, our call-in fees in the middle of the night are time-based. You need to have the proper time, or they won't get paid.
And again, if you're at a level 2 or 3 center where where kids and babies are being transferred to you, again, make sure you put where your hospital is too, because obviously if somebody in Abbotsford bills a neonatal or a pediatric fee code and the child ends up in Surrey or ends up at Children's Hospital, you can still bill for it and get paid appropriately, and just make sure you put sometimes you can put a note in saying this child was transferred from another site, but now I think MSP is getting better at looking at the hospital sites.
But that's very important. For example, neonatal codes, when a child gets transferred from, let's say, BC Women's, repatriated back to Prince George, I bill a day one fee. That's according to the fee code, and it's important to put in there transferred from Surrey Memorial, transferred from BC Women's. So that's where it's important to put in.
Baby, where's the port for the earphone in the phone?
That I can't help you with.
Jackie might be able to. What was the question again?
I think she needed an earphone port. So,
oh.
So those in remote sites, if you're not asking a question, please mute your microphones, because we do get a bit of an echo at times.
I think that it's already been dealt with.
So just enter, just next, okay. Okay, basically, consultation is your bread and butter. Somebody asks you to come to a C-section, that's a consult. Somebody asks you to see for a heart murmur, that's a consult. Somebody asks you for ADHD, that's a consult. They speak to you and you see the kids, that's essentially a consult. And basically, that's a 00510. We have 00512 down there. I can't remember the last time I billed one of those. Do you bill those?
Very rarely. If all of us, if I get a repeat consultation on the same child, and somehow they show up in 2 or 3 weeks, and if there's been some minor changes, then sometimes I'll do that, but very rarely.
I think with our extended visit fees, that's really not necessary, but anyways, it's there. So extended consults, it says chronic and complex conditions. Personally, I feel anything that takes me 53 minutes to see is chronic or complex, because I can't stand spending time with patients, so why would I want to spend 53 minutes talking to them? I'm just joking, okay, because this is being recorded. But I haven't given permission yet, Stephanie. I haven't signed those forms, okay? But so the bottom line is, you know, we took the route in designing these codes. If you look at the adult complex fees, they've got a list of, they need to have 2 out of 3 of cardiac, renal, GI, blah, 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 and they list like 30 basically conditions. We took it as, tried to make it more general. My feeling is you're a pediatrician, you're a specialist. If you're taking that long to see somebody, unless you're remarkably slow, it's complex and chronic, and that's the way I feel about it. Basically, if it's over 53 minutes, if it's 53 and above, because 53 minutes, presumably it's 53 in 1 second, 53 and above, it's a 550, which is significantly more than a 550. It's 68 minutes, it's 551. And that's important to realize. And it's going to be, it's interesting because initially we had the 511, they were, and we still have 511s, which used to be an hour and a half, but you'll see it's changed slightly, the definition. And so that's was supposed to be at 1.5, and it was kind of nice because it was about 220, 260, 300, 320 or something, then 400. So it's kind of, we did this time-based and kept it quite relative. The point there, and Todd, is important, I think you'd agree, is that you can use these in hospital as well. So if it takes you that long to see a patient in hospital, you bill those. And the reason we put that is that's very different from our follow-up fees, which cannot be used in hospital. And so it's important to be, or at least in inpatient use.
There was just a question that came up from the web about transferring babies from maternity ward and then admitting them into the nursery. Can you bill at day one? And so again, if you're obviously if a baby's out with mom and then they have a possible episode of sepsis or an apnea or other things where they need to be transferred to a higher level of care, then then what would you suggest? I would normally suggest that if they're admitted into the nursery, then you do start with the day one.
Yeah.
The only caveat to that is if this is your patient and you've been following them along, would you still agree with that, so if you see them yesterday and you did a consult on them, and then all of a sudden the next day you have to move them into the nursery, would you still bill a day one?
I probably wouldn't. I'd probably bill a day two for those. So if I see a kid and they're an infant of a diabetic mom and I say, look at you guys, quit worrying about it. The kid doesn't look, like it doesn't have the dysmorphology of an infant diabetic mom, like he's a normal kid. The next day when he presents with a sugar of 0.2, I just sort of like, no, maybe it's just a day two rate and I'll look after him rather than, so yeah.
I think if it's probably somebody else in your group and you have to go back and redo a history and spend a little bit more time, then I think you could maybe argue that you could do that. So I think you sort of just have to play it by ear, and like many things, that's one of the sort of gray zones.
Yeah. So I mean, a lot of time, for example, one of my colleagues will be at a section, the kid is well at birth, and then they have some sort of spell or respiratory distress 36 hours later. I would bill a day one.
Yeah.
You had a question?
I just want to clarify that for a 550, the 53 minutes refers to face-to-face time only?
It refers to FaceTime.
FaceTime.
Yeah.
And then the brackets 1 hour that you had on there?
Let me just go back. Ignore that.
Well, that's just sort of, unfortunately, that's sort of my shorthand is when we created these billing codes. In my head, when we create these, I essentially break my day up into 15-minute blocks in my head and say, okay, if I'm spending 15 minutes, half an hour, 45 minutes, an hour 45, these are the usual things that I would bill. So that's why I broke them up that way, just sort of in my head. But the billing codes, the reason we set the minimums is so you can get away, obviously, if you're not seeing them for exactly the hour and you're seeing them for 53 minutes, then you could still bill for the hour. So it's just the way it's worded, but that's just the way I do it in my head.
So because these are odd numbers, but basically we said a consult is 45 minutes. If you do it faster than that, great. If you do the majority of the next 15 minutes, it's a 553. So that was where the 53 came from. And then if you do the majority of the next half an hour, it's another 15. So it's 53 minutes, minimum 53 minutes face-to-face time. It's 550. Minimum 68 minutes, 551. Sorry.
And just kind of following up on that, if there's like house staff that are working under you, how does that work with timing if
it's your time?
Your face time.
Your time.
Okay.
Yeah, and we'll touch maybe on house staff at the end, because there was a few questions about that, and but again, just the basic issue is, the example that MSP likes to give when we have the meeting is if you're an anesthetist running 2 rooms and you have an R4 resident working in 1 room and you're working in the other, you just get paid for the one. So that's a pretty clear-cut issue for anesthesia. For us in pediatrics, it's a little less clear-cut, and I think you can, I think you can see how your day goes. If you have a 6 or 7 or 8 hour day where you're seeing 12, 14, 15, 20 patients, and you have a resident seeing a few patients, then you balance things out and see how you best get paid for your time. But you can't get paid, in my mind, when I break it up into 15-minute blocks. You can't be paid twice for the same 15 minutes.
Yeah. I mean, I routinely run resident clinics, and so I've got a resident seeing person while I'm seeing follow-ups. When they come and spend 20 minutes talking to me about it, and I go and see them, it's a 510. Doesn't matter how complex they are. If it normally would be a 511 that I'm seeing them, it's still a 510. Now, occasionally you get ambushed and the resident comes in and they've done the shittiest history ever, or else it's a terrifically complex person. You end up spending quite a bit of time with them. Well, then you're going to bill your time. But it's your time, not the resident's time. I mean, you're not paying the resident, so I think that's fair. I mean, we are indirectly, but so is everybody else in the hospital here. Okay. Do you want to talk about 511?
So we finally, for those people that have been billing for a few years, I think they know that MSP has would just like to collect more data. And for those of us in pediatrics, we really don't care, but because we spend the time with the patients, they're trying to collect data, especially around surgical patients where surgeons were billing consultations all over the place. You know, they admit somebody with a broken hip and all of a sudden four orthopods have billed consults on this one person who's been in hospital for like a week. So MSP is trying to get a handle on that and saying, look, if you're going to bill a consult, we want you to put the times on the chart somewhere. Now that created a few problems for us because we have this 511 code where we actually only have to spend, it didn't really specify how much time we actually had to spend in face-to-face time with the patient and how much time total by the time we went through psych ed reports and PT, OT, Sunny Hill reports, and then finally came up with our own report, our own consultation. So it was a little bit, the times were a little bit unclear. But when the whole reason this came about is, like I said, MSP wants to track doctors' time a little more effectively. And obviously I don't think they're targeting pediatricians, but this created problems for us for this 511 code. So Avon and I met with Tariff a couple months ago, and we sort of conceded. We were arguing with them back and forth. We said, oh, can we get by with 45 minutes FaceTime with the patient and the other 45 minutes doing our paperwork? But we had to concede to an hour with the patient. So the new note coming out for this fee code will be and what you write in your chart and what you record is your hour face-to-face time with the patient, and then the extra half hour can be doing reviewing these other reports and other things that you should have on the file.
And so to be clear, this isn't out yet. Okay, so there will be a note. Currently it's an hour and a half, and you might have to fudge that because it says, you know, this current fee code says an hour and a half is like includes face-to-face and reviewing, and so you have to put down an hour and a half. But it will be an hour face-to-face time that is documented with the understanding that it will take you another half an hour. This isn't totally ideal either, because if you see, it's actually less face-to-face time than our 551, which pays less. And it's also, this is one area where it's not complex or whatever, it's specifically for complex behavior and developmental psychiatric conditions. So behavior, development, or psychiatry, which includes just about everything, but not everything. So it's to be aware of that. It's not somebody with cardiac disease who comes in and you spend an hour and a half trying to sort out and they're crashing on you with SATs going on. That's unfortunately not that. That would be your 551. Let's leave that.
Peter? Yeah.
So for now, we put an hour and a half.
Well, they're just about to come out with it. It's already gone through tariff, so I'm not quite sure when it actually gets put into the computer at MSP. So we can keep testing it and see, but you should, as Bill said, they should, usually MSP sends a little, whenever they change a note on a fee code, they send it out. So I haven't seen it in print. Hi.
Hi. So for billing the 511, there's also a note saying that I can't bill a multi-D conference within less than 3 months of billing a 511. Unless it's medically indicated. Are there any specific specifications to what the medical indication is?
Yeah, no, I'm not sure how that snuck in there really. Like, again, for me, if you're, part of that is because part of this 511 is you're supposed to be reviewing all these reports and stuff. Yeah. And if you need to talk to somebody for 5 minutes, then maybe that could be included. But if you're having an extra 15 or minute or half an hour multidisciplinary meeting with other professionals, then I think you could just argue that, this was a complex patient, it took this extra time, and I think that's fine. Okay, so you could maybe put a note in the field and say that this was complicated and why you needed to spend the extra half hour.
And some of this is mute in a sense, because when we created these fees, we didn't have the complex follow-up fees. So let's say, for example, I'll give you a great example. The other day, I had a learner from here see a patient, and seemed straightforward ADHD, and as most learners, like, well, dad died, but I didn't feel comfortable asking why. It's like, really? Okay. So I left it. when I go back and I have all these sort of little notes like, didn't ask this, didn't ask this. Well, it turns out Dad had multiple drug issues, this, that, whatever. Turns out Mom did as well. Turns out that the baby had NAS. There was a lot of stuff that I spent a lot of time with. And so technically, probably if I'd seen that baby initially, it would have been a 511. But in a sense, it was irrelevant because I spent half an hour or more. And so that was a 554, which we'll talk about in a second. So that's $200. I mean, that and the initial 220 is basically the same as a 511. So initially when 511 came in, it said that, you didn't even have to do it over one visit. You could see them first and you go, oh God, this is going to take forever. I'm going to bring them back and finish the consult. Mm-hmm. Now, in reality, I don't know anybody who does that. It's just easier to bill the consult if you don't have the time to do it initially. And you can bring them back. I mean, the paperwork, I guess, is part of it if you've got tons to do and the patient isn't there. But oftentimes, they come back with some of the stuff that you've forgotten. So you're reviewing the psycho-ed when they're there. You're talking to them. It's taken 40 minutes. It's a 554. You're being paid adequately for it. It's not quite as important. So I think sometimes, even if it doesn't sort of qualify in some of these things, there are other ways to make sure you get paid reasonably and it's fair for everybody.
Yeah, and sorry, I'll go back and have a look at the conference fee code because you'll also note that now the Specialist Services Committee also has a conference fee code. So they have different definitions and qualifications. So we may have to go back and strike some of that stuff from our pediatric one because as Bill said, that was created a long time ago.
Does anybody in the periphery have any questions? If you want, just interrupt us and ask a question. Anybody who's on telehealth?
We did get this WebEx one about multiple billings on the same day, and we'll come back to that.
Yeah, that was for NICU, so we're going to leave that. Again, 00507, I would say, is your bread and butter for office visit follow-up. And it's quite different for hospital visits. So office visit about $67, hospital visit is close to 100 now. So it's basically straightforward. I'm not even going to talk about 514. I mean, I probably bill one or two of these a year. I mean, counseling is this bizarre thing, and I think really has been superseded by our time-based complex codes. Todd and I created these codes. It wasn't totally by choice that we had time-based codes, but that ends up how they are. And the important numbers are the 10, 20, 30, and the 12, 23, and 38. And again, it says chronic and complex, which is left purposely vague. And again, I think if you're spending that much time with a patient, unless you're talking about their golf score, it's probably okay to bill those, okay? And it's 10 minutes face-to-face time with at least 12 minutes total. Now, I don't know about you, but I dictate everyone, I sign them off. If I spend 10 minutes, it takes me at least 2 minutes to dictate, to sign it off, organize follow-up, say goodbye, that type of thing. Similarly, the 553, which is 20 minutes with the patient and 23 minutes minimum total, I bill. The prolonged one is 38 minutes, which means 30 with the patient. Occasionally, I'll see a patient I spend 30 minutes for, and it's just gone that long, and I don't bill that. I'll bill 553 because I know
they gave us a local phone number after 10 minutes.
So occasionally I'll bill a 553 even though I spent 30 minutes with the patient because it doesn't take me that long to bill. But usually I will bill those. So it's 10, 20, or 30. Those are the times, face-to-face time you have to document with the idea it's 12, 23, or 38 minimum. You'll see Todd put 15, 30, and 45 because that's how his brain works. He's booked 15 for them. He's booked 30. He's booked 45. And again, this is where it comes to, where you're at. And again, there's aggressive, there's whatever. I mean, when we go to SSPS and we start arguing with other specialists, they go, what the hell, your pediatrics, it says 10 minutes, 12 minutes, you bill 5 of those an hour and you bill $507.50 an hour. That's how much you're making. That's ridiculous. I bill 15-minute visits for every patient, follow-up patient I see, and I don't bill 552s on all of them. I mean, you know, some of them come in and it takes, oh, you're on Concerta 36, you're not having side effects, you're growing, here's a prescription, buy, see you in 3 months or whatever. That's a 507. And others that come in for, you know, 19 minutes and it's still a 552, it's a little more, but it's, you know, so it depends how you want to do that, but that's how to fill.
Where do you have to record like that extra? So say you spend 3 minutes basically with patients.
So you don't. You don't have to. No, and that's why it was nice, especially, you know, it's really hard to clarify things with MSP and you're back and forth for many years, but I'm really happy. I'm hoping that they stick with the language we did with the 511 because it specifically says in the 511, you only have to document FaceTime with the patient. And I think tariff committee, in discussions with Avon and I, they're pretty much of the opinion that we document face-to-face time. That's really what MSP wants to know. And as long as you have some other documentation on your chart to show that, you know, you did some extra things, then then that's really not that big a deal. So
most of us use electronic records. I mean, I think, you know, if you were shown billing from, you know, 8 in the morning to 8:30 at 554, 8:30 to 9 at 554, 9 to 9:30 at 554, till like 6 p.m. at night, and then they saw that nobody had signed into your EMR in the next 24 hours till you started it again, they would question you on that. But in general, no, you don't have to document it. And basically, if you spend 10 minutes with the patient, as I say, you almost certainly are spending, by the time you've done all sorts of other stuff.
And also we actually got it was a bit of a coup that we got this extra time for paperwork because MSP has completely been against it for eons. So really, it's probably best not to advertise with other sections to say, hey, you guys, look, we got extra money for writing our consults because really nobody else has that, especially with these follow-up fee codes. So just let's go about your business and do your thing, and you don't have to advertise with your GP friends or other people that, oh, we have these fee codes that actually do pay us to do paperwork, because we don't want MSP to balk at it too much.
So in reality, most people, even in MSP, would agree that, look, if you're in the office doing work, you should be paid for it. And in fact, the person who didn't allow us, who insisted on the face-to-face, when I was at a meeting with her like a year later, she goes, no, I've changed my mind. It really, you're in the office, should be getting paid for it. And I mean, that's the bottom line. You really should be. You know, it's not like, you know, when you're reading that psycho ed report, you know, 5 minutes later, or you're dictating your report and you're going through the chart, trying to really sort out things and looking back, like, did I really get that? Like, what did happen when I tried them on that initial trial? You should be getting paid for it. But the way it is it's face-to-face time. I don't do immunizations, but you get paid for them. IM shots, peak flows. If you do peak flows in the office, urine dips. Most of us don't do that stuff. Do you do that? Any of you guys do that stuff? A little bit, yeah. There's fee codes. Okay, this is the next thing that a lot of us bill a fair amount of money, especially NICU codes, because if we're in the periphery, that's what we do. A basically is the respiratory support. If you need to tube them, it's A. They need, CPAP, continuous CPAP, it's A. I don't mean for resus, but you throw them on CPAP in the nursery. B is IV. Todd and I sort of disagree on this, but the preamble in NICU specifically says if they're for prophylactic antibiotics, it's not in there. So personally, I don't bill it for those. I mean, if you get a kid comes in, you're called to the delivery, suspected maternal choreo, the kid comes out screaming blue murder. You go, oh shit, the kid's great, but he needs an IV antibiotics. I usually, they come into our NICU because the ward refused to look after them, but they get a Hep block, IV antibiotics, they go out to mom to feed. I don't bill NICU codes for that. That's a normal kid basically. And level C, feeding and growing on, level C is anything else. If they're on a monitor in NICU, they're level C. And there's a significant difference with fees. The most critical thing about fees, the difference that people don't realize probably because you don't think about it, is when if you're in a nursery that has feeders and growers that are long-term. So after 10 days, because if you look at So, okay, so you start with day one. Let's say a kid comes in, he needs CPAP. Day one, or he's ventilated, he's RDS. Day two, he's still on. Day three, he's on CPAP. Day four, you get him onto IV, get a TPN. That first day of IV, you've gone to level 2 codes. But, sorry, you've gone to day 2 codes. So that's important. So it's great. You start over again, counting, because day 2 codes are better than day 3 codes. You never go back to day 1. Once they're in your NICU, you get one chance to build day 1 codes. And it's really irritating because sometimes they come in an IV and they deteriorate after midnight and need to be tubed. And that's day 2 ventilatory, which is way less than day 1 ventilatory. But it's okay. You weren't up all night, so that's okay. But day 2 starts again. So that's kind of nice. So you've got 5 days of on event. They go down to IV. You've got another 8 days of day 2 on IV. Then they go down to day 3 and you start day 2 again, which is not as big a deal now that our day 3 rates are almost the same. It's about $120 a day, I think, for day 2 to day 10 on level C, as opposed to 100 a day. The big difference, though, is the difference between 01533 and 00508, which we purposely made the same value, is that you can bill 01533 forever. So when they're in for 3 months, you bill that. You bill daily care. After 30 days of a kid on 00508, they aren't going to keep on paying you daily care. You need to have a pretty darn good excuse to why you still think you deserve to be paid every day, because they're basically sitting there. Probably you say, hi, nothing changes today, whatever. Does that make sense to you guys? Okay.
So example, so day 1, they have an IV.
Yeah.
So that's a level B.
That's 01512.
Yeah. And then day 2, let's say day 2, the IV is out.
So that's 01523.
So then they go to level C as a day 2 or level C
Day
as a
2.
day 1? Day 2.
Day 2.
Okay, that makes sense.
Yeah. Sarah?
I also just want to make sure, I think I was supposed to make wrong, and I think I've been underbilling now for like 5 years.
Good luck getting it back.
No, I know, and that horrible sinking feeling. You don't have to be at a tertiary center to bill level. So if I intubate a baby, I've intubated so many babies and
Transfer, yeah. You can be in FBU, family birthing unit. You can be in the emergency room, like you'll see for pediatric intensive care fee codes, and it's just much easier to bill. Yeah, you don't have to be in an accredited level 3 unit to get paid an A code.
Can you, for the critical care, it says you can see in transfer BC. Is that for neonates as well?
Yeah, if you're in emergency and a child comes in on day 2 of life and you think they have congenital heart disease and you have to intubate them, then I would bill either a first day neonatal or pediatric intensive care fee code, and then if they're transferred to BC Children's, they can deal with it whatever they want.
So the trick with critical care is you can't bill time-based codes for critical care, and that can mean a big difference. Let's say you get called at 2 in the morning for a 2-year-old and you're there for the next 3 hours. It may be worth your while to bill consult and maybe 0081s or whatever you need to do.
So the surcharge, the after-hours surcharges, you cannot bill with pediatric intensive care. You can with neonatal intensive care and with our consultations. So you can bill your after your first half hour, then you can bill your extra half hour surcharges. As Bill said, if you're sitting there for 4 hours, then it actually even with an older patient, then it might be better not to bill the PICU fee code. And also now that we have the DKA fee code, since a lot of those patients were DKA anyway and are covered by that now, there's not too many patients. So, you have a child who comes in with a seizure who might be intubated and followed for an hour and then extubated and then figure out what to do with them. Again, you can decide based on whether looking at a 1 hour pediatric consultation and some extra surcharges versus doing a pediatric intensive care comprehensive billing. Again, it's really a flip of the coin.
And Sarah, you looked, it's like, what's a 0081, 0082? So these are emergency codes, basically. So essentially, and they may be more relevant and actually as lucrative if you don't have, because I'm a bit vague on whether the NICU codes have to be in a NICU somewhere. It doesn't certainly have to be a tertiary center. We have a NICU, but if you're not in a NICU type center, But 00510 is good for the first half hour. If you're like busy intubating and doing that stuff and standing there trying to resuscitate a kid, 0081 for every subsequent half hour basically of doing that. And then if you need to be in attendance just watching and they're stable, it's 0082. And those can be billed with time-based codes. So I mean, if you like, that's an extra 150 an hour of 1206s in the middle of the night, which can't be billed with pediatric codes, but they can be billed with NICU codes. So that's not the difference there, but it can make a difference. So you can look at that option as well. There's 00081, 00082. Just
Yeah, and
they're under the preamble section.
And it's really hard to get those paid. I gave up over the years. You can keep trying if you want. Sometimes you actually literally have to photocopy pieces of the chart and send it into them and say, look, I really was at the bedside, or I was really monitoring them. I was really back every 10 minutes monitoring this patient. And even then they don't bother paying you. So
You just have to write a letter. Usually a letter is good, but you have to dramatize.
Yep.
I have a question about kind of more adult-like codes. So say I'm in the office and do a urine pregnancy test, like a rapid urine pregnancy test. So there's a code for it, but it's under the family medicine.
So we can bill all family medicine codes.
Okay.
Except for their except where they specifically say that this is only for the GPSC or full service family doctor, but the majority of them we can bill. You know, if I end up seeing a 20-year-old for a follow-up visit, then I'll just bill a GP visit.
Okay, and so for the kids that I see for opioid replacement therapy, do I just bill them as a pediatric consult?
For which, sorry?
Like, say I'm following a kid for opioid use
Yes.
disorder, and then, but do I still continue to bill them as a pediatric code? Say they're 16.
If they're 16, yes.
If you're a pediatrician, then we can bill up to 19, and then sometimes in special cases even older. But usually after that, you have to switch to a GP fee code.
Okay.
So one of the people agrees with Todd that he basically never gets paid for 0081, 0082. Maybe I just write better letters.
Probably.
But that is one of the advantages. I mean, that's the advantage of the critical care codes, is they're easy. They get paid. You bill a 01512, you get paid. A 01423 or whatever, you get paid. But the trick is the older critical codes, like the pediatric intensive care, if you're seeing them off hours, it's kind of crappy because you're there for 3 hours, and you know the surcharges almost pay as much. And so they're designed for somebody who's sitting in the critical care unit for his 8-hour shift, but not when you're called in at 3 a.m. to spend 3 hours in the hospital. So that's when I really would probably bill 0081s and just write a really good letter. Chemo, sorry.
What if you're waiting for someone to come pick up a child, like for transport? I know you're not supposed to bill for time that you're spent waiting, but if you're bedside with a patient that you're worried about is going to be taken
That's
out?
the 0082s.
Okay.
Yeah, so you should read those. That's basically 0082s, or if you're on a transport with them. Yeah. The chemos will direct you to where they are in the book. They're pretty well described. There's limits. The major, none of you are going to be billing, or the intensive one, I think, is the big one. There's 3 levels. The highest level, none of you are going to be billing outside of BC Children's because they're basically inpatients, and I don't think, maybe Surrey does, but I doubt even then, because that's really the very intensive stuff requiring inpatient care. The next level is multiple parental chemotherapy, multiple parenteral. So that's the one that does get billed, and it's quite lucrative actually. So they come in, let's say you're seeing somebody for maintenance ALL monthly, or maybe it's even weekly. They get IV methotrexate and vincristine or something like that. That's pretty lucrative, and you just need a history and physical and whatever, and it's quite quick. And the minor one is if they just get even an IM shot of chemotherapeutic agent, you say hello to them. So those are quite important to look at, and that was good. Todd, you want to go about hospital visits?
So hospital visits, I think, have really helped for. We really bumped up those fees a few years ago, and I think they've really helped a lot of general pediatricians and subspecialists that still bill fee for service. So again, over $100 a day for a hospital visit. There was a question about multiple visits, and you can do multiple visits if it's a complicated patient or their status changes. So you can do that. You just need to make those notes. Again, the directive care, a lot of us would like to see the directive care change to basically whenever, sort of as needed, especially again for complicated patients in BC Children's Hospital that are seen by multiple subspecialists. But that's just something that is still not sorted out yet. Again, procedures, just remember your IVs, your LPs for young kids or older kids.
Sorry, I'm just going to interrupt, Todd. So that's Sunday to Saturday. So you can bill directive care Friday and Saturday. That's 2 a week. Sunday and Monday, you can bill 2 more days. So if you're lucky, they come in then. If they come in Sunday, you're screwed. You know, Sunday and Monday, you have to wait another week until you bill the next 2. I didn't write the rules, okay? And as Todd says, this is something we've been trying to change because you'll have, you know, we get grumpy little calls from endocrinologists, nephrologists who are seeing these incredibly sick patients daily at Children's, and they can bill twice a week. It's not fair. So
again, the procedures just need to keep an eye on, but I think we get paid okay for those. Our new DKA fee, I think, has generally gone pretty well. And again, when that whole time-based issue came up, there was back and forth with MSP about time, and that's totally been removed from this note. So you don't have to, other than when you originally see the patient, you don't have to write down all the different times when you either go back or get phone calls about this patient. Just like our ICU fee codes are the same. You know, you get paid for that 24 hours. You don't have to document, you know, other than the important things we have to document in our progress notes. You don't have to document every little thing. Our antenatal consultations, if you're dealing with a fair number of deliveries in your hospital, then maybe make sure you develop a relationship with the obstetricians, and maybe you would like to see some of these mums ahead of time, either in your office or in the hospital. If mums are coming in with more complicated issues that you would like to talk to them about, you can bill an antenatal consultation, and that works out well.
we didn't answer this one for NICU fees. Okay, so let's, should we address this? This is a hard one.
So one of the questions from online came if my colleague admits a well baby, and then that baby gets sick in the same 24 hours, and then someone else bills an NICU fee code, MSP will sometimes just pay the person who bills the NICU fee code, and they strike the other person off and say, no, we're not going to pay your consultation. And that's sort of a bit of a fight you have to have with MSP to say, look, I saw the patient, my partner was in 12 hours later and admitted them to the nursery. It doesn't mean it doesn't mean I shouldn't be paid for doing the initial consultation.
So yeah, I think there's no right answer to this, but I mean, if you're called for delivery and you spent sort of 45 minutes waiting for them to do the routine section, the baby's well, then you bill a consult, and then you just have to stand up and say, listen, I saw a consult for this. You know, the baby subsequently got ill and was admitted by colleagues to NICU. You know, I wasn't incompetent. I need to be paid for it, basically. I don't know. It's one of those difficult areas. And you know, it's just a fee guide. I spend not a lot of time, but spend time on the phone with MSB sort of saying, why didn't you pay this? And most of the people there are really great. There's one exception. And you can ask me his gender later. But you know, if you explain these things, most of them are okay. Sometimes they're not, and sometimes you just say, oh, the heck with it, I'm giving up on this one, and it all works out in the wash eventually. But that is a good question.
I think we'll come to that one.
Okay.
With the SSC fee codes.
After hours billing are really challenging. I find them very frustrating because there's basically your 1200, 1201, 1202 for callbacks. Are you all familiar with that? So basically these are if you're called in, and they're supposed to cover your visit to the hospital essentially, which is fair enough, I suppose. But, you know, if an obstetrician gets called in for a section, to do a section, he bills that and then immediately does the section and bills 50% of that if it's after hours, whereas we have to basically be there for the section and go home with the one fee. So not really fair. If you're there for more than half an hour, though, after 15 minutes, you can bill the next fee code, which would be a 1205, 1206, or 1207. And essentially, there for your time. So it's kind of perplexing because you're called in at like let's say 3 in the morning for a section. You get called for driving, you get paid for driving to the hospital, but they don't pay you any extra for that first half hour. It's inconceivable to me, and we're working on it. The 1205s, 1206, 1207s, I always write CCFPP in the comment code. It says continuing care from previous patient. I do that even if it's the same bloody patient, because I find it gets paid that way. So if I bill a 1205, 1206, 1207, I automatically put in CCFP in the comment code, because otherwise they question it. Whereas they shouldn't. I mean, you've got that patient billing, 7 p.m. to 7:30, 1200, 7:30 to 8:30, 2 times 1205s. You shouldn't put it in there, but maybe you don't have to now. But I found whatever software initially was knocking those off, so I just do that routinely. But it's for, let's say you get called in for, at 7 p.m., then you get called to the next patient. So the next patient from 7:30 to 8, you'd bill CCFP 1205. From 8 to 8:30, when you see the next one, the same thing.
Yeah, and like Bill said, we're dealing with this. This has already gone through tariff, it's already gone to MSP. This money we already have. We've told them we would like to spend some extra money on our evening and weekend and nighttime work. So essentially, coming up fairly shortly, every patient you see in the evening or at night, you should get an extra surcharge, even on top of these other ones. So for people that are doing lots of after hours work, you should get a boost of, I think, $30 for evening, weekend, and $100 for patients at night. And this is on top of these other things, and that's going to be for every patient that you see.
Because we feel we get ripped off in the middle of the night.
Just to clarify, the start time for a code for, like, you got called into delivery is not when you get there, it's when the action board.
No. So, it's when you get called in. So if you're there for for sections, if they basically tell you, oh, if you're waiting half an hour for a section, no, it doesn't apply. But basically, if I get called in, if they say come now, and I walk into the OR and they're setting up and I'm setting up that's when I'm billing from. Absolutely.
If you're reviewing the chart, you're setting up your equipment. So yeah, 10 or 15 minutes there.
If you get called in at 10 p.m. and all of a sudden, whoa, we've been bumped. No, you can't bill from 10 to 11 while you're waiting for them to do the section. But no, in general, you get when you get there, you bill. Any other questions there? Peter?
So I guess that would work because you're billing under mom's MSP, because can you bill before the baby exists?
No. So occasionally what happens, that's a good question. Occasionally what happens, I get called in at 11:45 p.m. The baby gets born at 12:01 a.m. Yeah. I lie. So I just add 15 minutes onto the time. I say 12:01 I got called in, and I extend it 15 minutes and just make a note on whatever papers to document it that I was there for that much time. Because just MSP unfortunately doesn't have the capability to deal with that.
So maybe I misunderstood because I had this question once and I called them about it. They said I just have to write down the time that I was called to the call out, and it doesn't matter, like, that it's in a different day.
Who knows? The last time I called, they said lie.
And then I was really confused.
No, they said just budget. The last time I called, which was about 6 months ago.
Wow. When would you?
Certainly I found it gets paid that way.
Yeah.
Previously it was a nightmare. Stephanie, sorry?
When would you choose to bill like a 505 versus like a 508 with surcharges if you had to assess like a peds patient on the ward?
In the day. You get called out of your office, that's when it makes sense. Because there's no surcharges. That's the only time it makes any sense at all.
So at night, if you get called to the P's ward for whatever reason, you should be doing a 508 with surcharge.
Probably.
Okay.
Yeah, again, it depends on, yeah, you can look to see what's better paid, or sometimes they do balk at you billing another 508 if somebody's billed a 508 earlier. So if you want to avoid that hassle, sometimes it's just as easy to bill a 505 and not worry about it and say, the nurse called me, I came and assessed the baby, and I leave, instead of having to do the two billings. But
in general, it's a daytime code.
Because again, with your surcharge, unless you've been up all night seeing patients on a continuous basis, if you have a break in that, then you get called back an hour later, then you can't bill a surcharge for unless you spend more than half an hour assessing them anyway.
I didn't know you could bill a surcharge on a 508, so you can?
You can, like, not routinely. So, I mean, this isn't for making your rounds on a Saturday.
Yeah.
But, I mean, let's say I go in at 10 a.m., and I see the patient, and then I get called in at 7 p.m. because the nurses are concerned his sats have dropped, he's looking like hell. I will bill a call-in and then another 508, and I'll specify the time on both of those 508s, and often make a comment saying patient deteriorated, called in because blah, blah, blah. And generally that gets paid.
So one of the questions that has come up online is for extended for extended hospital visits. So again, we all have our complex patients in the hospital for extended visits beyond a 508. And the way our fee codes, as Bill said, we bill our office-based fee codes. We have our 552, 3, and 4 we can bill, but not in the hospital. So you bill a 508, you bill, and that's just the way it is. Even if it's a complicated patient, on the day of discharge, as you probably know, and we'll talk about it with the specialist fee codes, you can bill a discharge planning fee if the patient's been in hospital for more than 4 days. So that might help you compensate to try and answer that question.
I mean that's the beauty. I mean, I think our hospital codes are pretty good. If a patient's in there and you're getting $9,500 every day, basically, they're way better than they used to. And again, people bitch, they go, oh God, it took me 20 minutes, 30 minutes to see that patient. I do a lot of hospital work. Some it does, but others it's like, hey, how's it going? No problems with the IV antibiotics you're on? Good. Poof. See you tomorrow. So it kind of works itself out in the wash. I think they're fair codes, but I mean, it'd be nice to be able to develop it, but at the moment I think they're fair.
Would you use the 508 for like a let's say you're coming to see a Billy follow-up in the hospital, a baby that you didn't see but is coming back?
No, that would be an outpatient visit. That's a 507. That's basically an office visit seen in a hospital, in a hospital clinic, but it's not an inpatient. The 508 are inpatient codes.
Inpatient only.
Yeah. So, I mean, if I've kept the baby in and the Billy is this and I send them home, it's a 508. If I sent them home and I'm bringing them back to the clinic to see them and the Billy is whatever, it's a 507 or 552 if you spend long enough with them.
Group visits, again, the fee codes are there through the Specialist Services Committee, and we'll see that more on the next slide. People use them for group counseling, for anxiety, ADHD, asthma, other things, and the fee codes are listed as far as how you bill them for the patients that are there. And I don't know too many pediatricians that do it, but the opportunity is there if you're doing a lot of that kind of work.
And then the case conference, which I think are great fees. They're 00545. There also are some SSC codes that can be used. And the only advantage of those, because our fees are better, but they're great because, I mean, nowadays, now you can meet with basically anybody about this kid, and you just have to document it and you can bill it. The limitation is, I think it's an hour and a half a year, or what's the limit? I can't remember, but there's a limit to how much the 0545s can be billed in a year. So that's where the advantage of actually the SSC codes are, which aren't quite paid as well. But let's say this is somebody you have to meet with the school again, and you're like, you're on 4 case conferences a year with this kid. You can bill the SSC codes for that. So it's kind of nice.
Do those have to be face-to-face?
Well, you're face-to-face. It's not with the patient.
Right.
You're discussing with, it might be the teacher on the phone. They can be phone as well. So it might be a teacher on the phone. It might be a social worker. It might be, 4 of you. So you have to be there. It's not for letting one of your trainees talk to them for an hour or whatever. You have to be there, but it's not with the patient. I bill the 1001s quite a bit when I'm on call. They're great. It doesn't matter if it's 2 minutes or 12 minutes. It doesn't matter. It's $60. And it's kind of nice because I don't know about you, but when I'm getting my pager going, well, I don't have a pager anymore, my cell going off when you're in the middle of trying to do something and it's going off 12 times a day, it's nice to be able to get paid for those. It's rapid advice fee, so it's within 2 hours, but I don't know how you guys feel. I rarely get somebody calling me and say, call me back within the next 3 days. They want to know now. It doesn't matter if it's the most benign thing or not. I don't assess that. They want me, and they want me right away. That's what I bill. Recently, it was irritating. Nurse practitioner previously, you couldn't bill that. You can now. For whatever reason, they would just pay you the 1002. And that I felt was really biased towards both the nurse practitioner as well as peds, because we could probably get more calls from them. But now midwife, nurse practitioner, anybody who calls you, you get to bill for it. They changed it slightly, so it's a bit unfair. You get called, let's say, and you spend 15 minutes speaking to them about this patient, and then 5 days later, they call you again about it. You can't bill that unless it's a different diagnosis. So you can bill the same diagnosis, I think it's within 6 months. So if you're seeing somebody for constipation and then the GP calls you because they just have a cannonball that they're trying to pass, you can't bill that, okay? And the other thing about it, that's about it. Anything else with the 1001s? You just have to document. What you need is the date, the time, who called you. So as soon as I get a telephone call, I've got a piece of paper, boom, on this side, the doctor's name, the date, 1001, and the time that he started the conversation, and I'll fill that out at the end. What's the patient's name, birthday, PHN, boom, and then just a story, scan it into EMR at the end of the day.
So just to catch up on a couple of the questions here, we did have a note here from our colleagues in Victoria to say that they've actually been paid 508s on a fairly continuous basis for some of their chronic inpatients for different reasons, and they've never really been refused over time. So that's good. We don't really anticipate any changes to that, but you're never sure. MSP, much like for these time-based things they've done with consultations, sometimes MSP gets a bit of a bee in their bonnet and all of a sudden something changes. So we just need to keep an eye on it. But that's good to hear that people have been paid 508s on fairly extended times. There's a question here. About pediatricians covering for oncologists in a regional center. The question is that we've been billing histories, physicals, and reviewing orders. If you didn't know the patient, and I think it's appropriate that you get paid for that. I'm not quite sure exactly what you've been billing here, but if that patient is new to you and you're spending the time with that patient, then I think it's appropriate for you to bill for your time.
Yeah, I mean, I think it depends on your setup. I mean, it's the same type of deal if you're in a group of pediatricians and you're sharing a call. I know in some places, like your Billy question, the person comes in for a bilirubin the next day. I think in some places the next pediatrician would bill a consult. I don't think that's legit, but I think it happens. So I guess I would say if you're covering for the oncologist, you're not part of their group, but you're there, then I would do a consult. Like if kid comes in with febrile neutropenia and I don't know them, or even if I do and it's a new problem, I'm going to bill a consult. I mean, if you're doing CA work, or maybe not CA work, but if you're involved sort of in some formal arrangement with the oncologist, then that might be different. The way and it's tricky because I don't know what the right answer is. I mean, Todd mentioned this ortho thing. MSP caved to the orthopedics, and so if you're on call for orthopedics and you see a fractured humerus and you say this kid needs an open or adult needs an open reduction, but hey, we didn't get to it today, so it's the next ortho. The next ortho bills a new consult, and that seems to be fine. I don't think that's legit. If I was MSP, I would have gone bonkers because the way I view it, I sort of look at it. What would the patient think is reasonable? I think somebody comes to see me and I'm paying him $200 for a consult and he says, oh, I didn't get to it. My colleague will do it tomorrow. And the colleague comes and charges me another $200 for the consult and they don't get to it. And the next colleague charges me another $200. I would be pissed. And so that's the way I view it. And that's kind of the way we certainly at Prince George, we manage our things. We don't bill consult after consult. But if they come in with a different problem, absolutely. Or let's say, it wasn't a planned follow-up. I mean, it's a complex patient with CP and they come in, with aspiration 2 weeks later and it's one of my colleagues, I'm going to bill a consult. But these are difficult kind of questions.
We have a question from Kamloops.
Is this the question?
No, the question from Kamloops is on my phone. Should we do that one first?
So there's a question that came in. Sorry, your mic's not working, but also Jackie is our technical assistant is taking notes on WebEx. So one of the questions here: would you consider high flow nasal prongs as ventilatory support? Again, I think some of it depends on how sick the baby is. If you're using it as pressure support, which many places do, similar to CPAP, and you're monitoring the baby and the baby is sicker than average, I think that's reasonable. If you're just doing it to deliver oxygen, then that wouldn't be considered ventilatory support. The other question here.
Delivery consult time when we arrived as opposed to time of birth. I would agree with that. With the caveat, I mean, if you're talking about call-in fees, absolutely. I mean, if you're talking about consult fees, I mean, I've never billed an extended consult for delivery. I mean, it's a consult. I mean, sometimes you're sitting there and it's like you've got the slowest obstetrician who's ever walked the planet. It's a consult. I mean, despite the fact that, I'm pacing and making obscene faces and chatting to the nurses and making inappropriate remarks, I mean, it's still a consult, not an extended consult. Somebody asked, how do you document a G1001 if doing locum hospital work? You need to patient's chart. I mean, if you don't have an office, I probably would dictate that. I mean, it's a bit tricky, isn't it? Because they may or may not have a hospital chart. So I don't have the answer to that because I scan it into my EMR, and it might be something, if it's not a hospital patient, you're doing that, you might just want to get, call one of the companies and get sort of a part-time EMR anyway, that you can keep some of these records.
I could maybe speak to that. When I was in Kelowna, I had that.
Are you using the mic?
Yeah. When I was in Kelowna, I did that, and they transcribed it for me and then sent me a note saying, sorry, we can't transcribe this for you, and then I just kept the transcription of it. So.
Fantastic. There's another note here: in multiple physician office, can referrals to one physician be seen and billed by a different physician in the office? I think probably yes, absolutely. Like, more and more you get consults and you go, Dr. Abelson, please see, but I don't have the time. But one of my colleagues said, yeah, nobody's going to call you out on that. As long as you have the original consult note and you're in a group setting, yeah, nobody's going to call you out on that.
So one of the other questions that has come up with the GP Services Committee, they've done a really good job at facilitating full service general practice. Now they have a special fee code where your office assistant can be paid for calling results back to your patient rather than them coming in for a visit, but that we're not allowed to use that. That's for GP Services Committee. We don't really have a big plan to do that for Specialist Services Committee, nor have we put that on a top 10 list for billings that we would like to create, but if we hear enough interest from people, towards the end, we suggest if you have ideas for billing codes, let Stephanie, our executive director, know. So that's certainly something that we could consider. And then, but there is the 10003 for patient follow-up fee that
Phone follow-up.
and that's a phone follow-up with the patient if you're seeing how they're doing on their new ADHD medication. I personally haven't used it for lab follow-up and stuff, but if it's a significant issue, I think that's probably reasonable. Usually I just get my secretary to call them if the parents are really anxious about something and I don't worry about it.
I mean, it is something, it's kind of frustrating because follow-up is only $24. So let's say, you know, it's an ADHD patient. I mean, in the north, I mean, you're having somebody come back, see how meds are used, and it's an hour and a half ride. And, you know, it's dangerous roads. But you're kind of getting ripped off. Whereas telehealth,
I was going to say telehealth
is the full amount.
That's the way to go.
And so probably, I haven't done it yet, but with most of us are probably using a Curo. They have a product called Medeo, which costs extra, but it wouldn't take many telehealth visits if you're in a rural area, or even if you're not, because Vancouver, God, it could take you longer to get from Surrey into Vancouver than Vanderhoof into Prince George, though not with the road work at the moment, but something to think about.
There's some questions here about medical, legal, and telephone advice. And if you look under the MSP fee guide, there are suggested fees for those, but those are, unless you're dealing with Crown Counsel, those are generally fees that you charge privately to lawyers and doing medical legal work. And the Doctors of BC has made some suggestions about what your time and what your reports are, if you're doing a short report or a long report. And generally, most physicians follow those. And then, as I said, the fees are set if you're dealing with Crown Counsel. They've already come up with ways to deal with that. And I'm sure some of you who do more child protection work come up against this quite a bit. But so I'm not sure exactly where this question came from. So we're getting there, and just a few overall suggestions. Keeping a day sheet as you go through the day. Altering your times as you go if patients don't show up. If you're spending extra time with patients, making sure you make those adjustments either in your EMR or for somebody like me who still prefers to do it on paper and then scan things in later on, that's fine. But I have multiple years of my day sheets, whether they're in a book or whether they're separately, and I've written changes as I go through the day. And you're also supposed to write them on your patient chart, depending on your EMR system, whether it does it for you automatically or not. Again, keep track of the face-to-face time. When you're in the hospital, same thing. When you're seeing the patient, keep track of the time. And as I mentioned, we would just like to see some ideas for new fees coming forward. And I know people would always like to get paid for being pulled out of their office during the day to go to the hospital. They would always like to be paid for sitting around waiting for things, but MSP will never pay us for doing those things, at least unless there's a major shift. And just to be clear, even if we have money to do certain things, so we can get money through a recruitment and retention process or a disparity correction process, and that's where we tend to do the best in pediatrics, because if our ophthalmology and GI and cardiology colleagues, as you know, they all make 3 or 4 times as much money as we do on a yearly basis. So this is where we're trying to catch up and up and up. But even if we have money, it doesn't necessarily mean we can do whatever we want with that money. This is a negotiating process that we have to go through with MSP. And if MSP and the doctor section run into problems, then the Medical Services Commission is the final arbitrator on this. So some things do get taken to arbitration. If we really feel strongly we should be paid for a certain fee, and if MSP is dragging their feet, then we can try and push things along. But we've within pediatrics, we've always had a good relationship, mostly because we've had the money to do the things we want to do, and the things we want to do have been quite reasonable.
Sure.
Sorry, I was just wondering if you could comment. The suggested fees that come up in Acura right now for the private pay patients are like, there's an astronomical jump recently. So where did that come from? Like,
I think the board over the past year or two, somehow I think the board made a decision. Either, I'm not sure if it came from the surgeons or the plastic surgeons or whoever it came from. So now it used to be like a twofold increase that they suggested for a private pay patient, and now it's 3.6. So again, those are suggestions. You can show it to your patient and say, I'm giving you a deal. I'm only going to charge you half of that. That's totally your own business. Those are just suggestions. And I'm not quite sure why they chose the 3.6 factor, Avon. Do you remember? So it came out a couple years ago, and I'm not sure. I think there was a couple sections that pushed for it. So it may be the orthopods pushed for it to say, look, we're having, or maybe the obstetricians, they're having mums come from China and deliver babies here. How much should we charge them? And yeah, why not charge them 3.6 times what we normally get?
So it's up to you, basically, is the bottom line. I mean, some of them seem somewhat outrageous. On the other hand, I don't know. I don't get paid for all of them, which irritates me. So, I mean, my feeling is, unless, somebody's been just moved here, I mean, everybody's got the option to be a member, and it ticks me off when they don't have it for whatever reason, whether it's religious or this or that, or they just didn't get around to signing the forms. So it's extra. Yeah.
A couple of the other new things that MSP's done that I think you've probably all maybe come up against is, again, this time-based issue that we already talked about. There's also the issue of if we, for some reason, if we've documented the wrong PHN number, or the PHN number we have doesn't correlate with the name that we've been written on the chart, and typically, again, for babies, the names always change, which drives the secretaries crazy and our MOAs crazy. So it used to be that you used to be able to call MSP and automatically you could type in a PHN number and they would tell you the name. But unfortunately, they don't do that anymore. Now, probably for privacy concerns. So, I guess it's reasonable. Somebody could have called in and typed in a PHN number, and you see a name pop up. So now they send that information to your office, or where that's associated with your payee number. And that's a bit of a hassle if one of your spouses does your billing at home, or you have a separate billing company. Then if there's questions, then it gets sent to your MOA in the office, and what are they supposed to do with it? So you just have to be aware that they've changed that over the past little while, which is, again, a bit frustrating, because often that's where the issues are. It's just that link. Oh, I didn't put the right first name, or the parents are using them. Somehow something's changed. It was especially after the 3 months when you can't use mom's PHN anymore.
First couple of months, the baby boy and baby girl are really good first names.
Yeah.
Yeah, with a 6-6, I would definitely pick those, unless they're twins or multiples.
So again, MSP has good websites. The Doctors of BC, I'm sure you've all seen their website. The UBC CPD has done a general billing talk that highlights some more general things if you're new into practice. What is your MSP number? What is your payee number? What happens if I do a locum somewhere? What happens if I do, if I'm just doing my regular billing? Where does that money go? So those are all things that they touch upon there. There is also a little pediatric section for reminders.
So questions?
I know we've been doing questions as we're going through. I hope we've answered most of them here, and I thank Jackie for keeping us on track with the WebEx. We haven't. I'm not sure if we've done this before through WebEx, but it seemed. I hope it worked well for everybody. If there's other questions, then I hear some of the mics aren't working at the other centers. So if you have questions, then just let us know.
Well, that's a great question from Kamloops. If the baby is delivered by a surrogate mom, how do we bill for the baby? Certainly in the first couple of months, I would definitely use the the surrogate mom. In other words, the person who went into the hospital, had the baby, her PHN with a 6-6. After that, clearly, hopefully it would be registered under the real mom or the doctor, whatever you want, the new mom. But for the surrogate mom, you'd person who physically has the baby initially, the 6-6, or tick the infant box in a Curo and build baby girl.
And I do know some offices that the MOA in your office will physically help the mom register while she's standing there in the office with you. So if you're really having difficulties, then get your MOA to register the baby.
I mean, it's exasperating. I mean, I'm recently looking after a term kid, but he was born at 27 weeks, so clearly up over that 3 months. Mom still hasn't registered, and it's pretty irritating because they're not even getting paid for some of the neonatal stuff still. So you need to get them registered. I mean, you think it'd be automatic. They don't even have to pay for MSP in a lot of circumstances, but they do need to register.
So here we go for evening and night call service charges. Is it based on the time you were called or what time you started to see the patient?
So if you get called at 10:45 and start seeing the patient at 11:05, okay, that's tricky because technically it's based on, so the billing starts when you see the patient. So the billing starts at 11:05. Technically, you're supposed to put when you're called. One of my colleagues does that religiously. I have never done it in 25 years of practicing here. So technically, it would be based on the 10:45. In general, presumably, if you're seeing a kid at 11:05, you got called, you didn't wait and go, okay, I'm going in now. It's past 11, so I can bill an extra $20 or whatever. So technically, I just bill when I get there. It's tricky because even let's say you get called at 10 o'clock, or let's say you got called at 9. Let's say you do get called at 8 p.m. and you're just saying, oh, I'm having some booze with the buddies, and which you hopefully aren't doing on call. We're going to drink heavily until 11:01 when I get a chance to go into the hospital. Even if you tried to bill the evening codes, you couldn't. They'd tell you there was a time error. So you're basically stuck billing nighttime calls for that. And so it's when you see the patient. And I think you just have to be honest with it and not sort of, keep on getting calls at 6 p.m. and waiting till 11 to go in. I don't think most of us would do that anyway.
Again, if you're having the other time it comes up, if you're having a really busy night and you're popping down to emergency, seeing a couple of patients, then you're called back up to a C-section or a stat delivery, and then you go back to emergency. And so you really just have to look at, okay, let's say you just spent 4 hours doing patient service. You really have to go back and look at your times and see what makes sense. Who are you going to bill? Just pick a patient and bill a couple surcharges to one and then a couple surcharges to another one, and just make sure that it flows appropriately, even though in your mind you were back and forth 10 times.
So can you bill the call out for every?
No. You bill the call out when you get called out.
Microphone.
Sorry, Alex.
You were just saying when you're running around seeing lots of different consults, which code do you use when you've been called in and then you stay in?
You get the call out once.
For the first time. And
then after half an hour, you start billing your continuing care surcharges. So the call out is 1200, 1201, 1202. The continuing care, 1205, 1206, or 1207. So let's say you get called on a Monday night, 8:30 p.m.
Yeah.
So 1200. At 9 p.m., you're still there. And you're there till 10, you're billing at 1205 times 2. Oh, you got to see another 2 people. It's another 1205, another 1205, another 1205. And what Todd's saying is if it's 22 minutes for one and 38 minutes for the next, don't put 22 for 138. Just go 30 minutes or even actually just 2 of them for one, and just make a note somewhere else that, you were there continuously. I mean, I wouldn't bill all 8 of them if you're there for 4 hours for one patient, but you don't have to be exact. If you're there in the hospital working, not having coffee with the buds, you just are billing for that time continuously, basically. If you go home, on the other hand, or an hour goes by and you get called in again, or even if you know something's happening and you go to sleep, I'd probably bill a call out if I hadn't billed for the last hour for the next one.
If you're in hospital and you fall asleep and then you get called an hour later, is it the same? Or
so the question is, if you're in hospital and you fall asleep, whatever, I probably would. Technically, it's for driving in, but really there's so little difference between a 1200 and a 12, I don't think anybody cares. It's just simpler. I mean, if you're not billing continuously, like let's say the other night I got called at 3:20, I go to a section, it's finished at 4, I know there's another section, rather than drive home, and I'm only 2 minutes from the hospital anyway, I go to bed. And then at 6, believe it or not, when I get called for the next section, I bill just a call-in fee. I didn't walk to the car and walk back in, but I don't think anybody's going to mind that, basically. I think it's different, though. We're talking, though, if you're not being paid for in-hospital call, that's a totally different kettle of fish. If you're being paid for in-hospital call, that's really tricky.
One of our colleagues wants to know about what people are billing for disability tax credits, so you can think about that for a minute while we answer another question.
And you probably alluded to this already, but
Sorry, can you use the microphone because otherwise
yeah, it's on.
We're good.
Can't hear you. Oh,
Yep.
sorry.
Yeah. Just about transferring from one NICU to another, and just to clarify, what is the billing code for the person accepting?
It's a level
Day one.
Day one. Depending on the level.
Yeah, day one, whatever level.
Okay.
Usually day one, level C for those of us who are accepting in the periphery, because by the time they come to us, they're off ventilatory support. Certainly, they're usually off TPN. They're just being monitored for apneas and got an NG tube in. So it's usually a 01513.
Okay.
Starts over.
Okay.
Yeah, because you have to do all the work. You've got to review it makes sense. You've got to review all the discharge information and examine the baby again and get your new orders done
and redictate the discharge summary they sent you. Sorry, Peter.
I think in the same hospital we would do day 2, right? If it's like if NICU transferred to our step-down nursery. I think that's a day 1.
Yeah, that's a bit of an anomaly. So you just have to,
I don't know the answer.
I think some of it might just depend on how much work you have to do for that patient, and
You have to specify the city or something, though.
usually hospital. I think there's a special code in the billing for hospitals, but disability tax credits for 1 minute, and then a couple more quick questions. I know people approach it differently. How long you spend with the patient, whether you do it as part of a visit where you've seen the patient and you sit down and quickly do it while the patient's with you, how much information you need to photocopy and send with it. Whether they send you the stupid second form to do, which they seem to do more and more. So again, this is something you can bill the patient whatever you want to for, or you can bill the patient whatever you want. Again, as you know, most of the patients are already stressed financially, so billing them $25 or $50 is difficult sometimes. So I don't know what do people do. Do people charge patients privately? 25, 50, 75, 100?
You have a mic?
I don't charge patients, but I've learned to get them to answer questions ahead of time. And I filled out too many of those second time around so that I actually give all the questions to patients and they have to work to fill them all out, and then it's very easy. So that's how I save myself time.
Yeah. So it's interesting because I used to charge for them, and I've stopped because I do what you do, basically. I tell them to go online, download the form, or sometimes I've got it in my office, and I'll show them which paragraph that they need to fill out. Because I explain to them it's not because the kid has a diagnosis of ADHD, it's not because he's got a diagnosis of this, it's because they can't hold down a job, because the kid is a tyrant, because no child care in this side of the Atlantic will keep him. So they need to document this. And the better they document it, the less likely I'm going to have to fill out the second form, which I don't fill out either. I give it to them to fill out because I can't understand it. And basically tell them they need to document it. I say they're not going to pay it because of the disability diagnosis. They're going to pay it because of the impairment and what it costs them, not in terms of medication, because their medication is probably covered and there's MSP for the medical bills, but for what it does to their life. And so I get them to fill that out. And are you going to answer this one?
We've had a suggestion for the next webinar, and that's me sitting and auditing Bill for an hour in his office and seeing how that goes.
So thanks Keith for that suggestion.
And thank you, everybody. We'll see you in October at our annual conference, and we'll be here again.
We'll be here for the annual conference, and you can save those questions. So Stephanie, you're welcome to come up afterwards and ask that one last one.
Thank you.
Oh, and please fill out your evaluation.
Evaluation forms, so important to us. Evaluation forms.